Welcome to the Health and Wealth Power Hour, the podcast that provides you with the knowledge and insights you need to achieve physical, mental, and financial well-being. I'm your host, Harlan Pickett, a business consultant who's passionate about helping people achieve a more balanced and healthier life. Each week, we'll deep dive into topics related to health and wealth, including retirement income planning, innovative healthcare solutions, alternative funded health plans, and specific actions individuals and business owners can take to gain control of their finances, have access to affordable quality health care, and achieve peace of mind. We'll also be joined by innovative experts who will share their knowledge and insights on prevalent topics. So, whether you're looking to grow your wealth or improve your health, you've come to the right place. Get ready to be informed, inspired, and empowered. Let's get started. All right, and welcome back again to the Health and Wealth Power Hour. I am your host, Harlan Pickett. Boy, we got a good one for you today from the dark underbelly of healthcare. That's right. That's where this gentleman says he lives, the dark underbelly of healthcare, but close to the happiest place on earth. That's right. We're talking today to Timothy Poor. Timothy does something very, very important. Him and his organization help folks with post-acute care. That's their primary function. They also do some stuff kind of in the front side too to help you if you need that as well. But we're going to learn more about him. I'm telling you right now, folks, one of the biggest challenges, I've seen it through my family, I've seen it through clients, is what do you do when you get out of the hospital? That post-acute care can be very, very challenging. And typically, there's no one to help you. Timothy, tell me more. First of all, how you got here, because I noticed in some of our pre-conversations, it certainly wasn't where you expected to be, but talk about kind of how you got here, and then let's talk some more about what you guys really do to help folks.
Yeah, so I moved down to Florida and worked with my family, and I'm originally from Florida. I'm originally from where I live, and that's just outside of Orlando. And I want to get into actually I want to get into pharmaceutical sales. I want to be a drug dealer, and kept applying and wasn't getting it.
But Florida's a good place for that.
It is a good place for that. So I've heard. And I get but I got a job in post-acute care with hospice services, and I got a job there as a marketer as for ATP HealthCare. And they have pretty exceptional training. At least I think they did at the time. Dominic Nick was a very good corporate trainer, and I think he was probably too good because they were literally, other companies were literally picking reps out from the training sessions that they were having. But they had a very good foundation on making you understand what's going on in post-acute care. And I did that I always say it's a tour of duty because a lot of people work for VITAS in the healthcare world. Part of it is because of that training that they do. And I ended up working for a brief stint with a home health company. And then I as a favor to a good friend of mine, he kept asking me to take this interview with this company on a post-acute care side. I was really kind of hesitant because at the time I was working with a pharmaceutical company on what's called a priority review voucher. It's sort of like a golden ticket. It gets you to the front line for a pharmaceutical approval process, and really wasn't too interested in, but it was going to pay the bills essentially. So I sat down and took the interview, and they asked me how much I would want. I knew what the last guy got paid. So I was like, I really didn't want to do the job. And so I gave like a really ridiculous number. And the VP didn't even blink. He said, okay, you can start Monday, type deal. And I just I went out to my car. I really didn't want to do this. I think I started hyperventilating. I'm like, what the hell did I just get myself into? This isn't the direction I want to go. So reason being that they probably would have paid more for me is because they needed somebody because they were selling that region of the company, and they needed to have somebody who was going to be working in sales and marketing and admissions for those skilled nursing facilities in order for that deal to go through, because I was going to be covering a lot of buildings. And got purchased, stayed with the new owners, and ended up helping them identify and purchase other skilled nursing properties. And once we would purchase those buildings, we would backfill them. So essentially, we're working on, if you buy a skilled nursing facility or a new operator, the best way to get into with a hospital is to take some really challenging patients, and and that's going to definitely get that hospital's attention. And so you'll take those patients, and then you figure out like how your building is going to make money off of them and deliver the care the patient needs. And because if there's no money coming in for that patient, there's no care that's going to be delivered, no matter how deep your miracle bag is. And so I did that for a few years, and I decided I was going to go away and do something else. I wanted to work in helping primary care physicians stay independent, kind of like what you do. And so direct primary care was a very interesting model, and I was really started to study that a lot. But I kept getting these hospitals kept calling me and saying, "Hey, we got this patient here, not quite sure what to do. Would you just mind just taking a look and just give us your thoughts?" And so eventually we got to a point where one hospital, a director of care management, said, "You should charge for this." And we developed a payment model after that point, because I was like, this might actually pay the bills. And so that kind of that started ATP HealthCare. Now we're several years into it, and we kept seeing that this is the same issues are happening again and again and again. And anytime you see it, there's a repetitive sort of like activity going on, where you kind of say to yourself, I can build a machine to do this. And so we teamed up with another company, and specializes and analytics, specifically in artificial intelligence, and applying analytics for that. And we developed an AI platform to assist hospitals in identifying placement options for challenging patients, but then it also it works with the patient throughout their care journey into post-acute care, and either into long-term care or into back to their primary care physician. And we're currently deploying that with a health system. So and its provider. So it moved quite a long ways, and we got to really kind of see, like, especially working with these healthcare providers, both on the acute and post-acute care side, really get to see kind of like some of the difficulties or the stresses that they deal with continuously, whether it be a level 1 trauma center or a critical access hospital out in the middle of nowhere. They have a lot of challenges that they're having to face in delivering the best quality care that they can for those patients. No one sits there and wakes up in the morning and saying, I'm going to do a bad job today. It's like everybody that's in there, on the administrative side or even on the clinical side, are doing the best that they can for the patients that they represent. It's just sometimes it's very difficult with the circumstances that they're in for them to do what they want to do. And so we kind of work on developing systems in place where that makes it a little bit easier for those individuals to do the jobs that they need to do.
There's something that you said in there that really it struck a chord here, and I had to look back on some notes that I had made when I was originally planning on sitting down talking to you. And it's an interesting thing that I don't think too many people think about, even in this industry, and that's the fact that there are patients. I mean, you work with both sides. You work with the hospitals and facilities, and you also work with individuals and families.
Yeah,
right?
We'll also work with individuals. Yeah, that happens, and those are always the interesting ones, because that's like the Friday night 9 p.m. call, and it's like a family member is like, yeah, this is a situation we're in, and we found your phone number in a bathroom in the case management office. for a good time, call ATP HealthCare.
Right, but here's the quandary that people find themselves in, and it once again, it's not something I think people think about, because it's, maybe you can tell me it's more common than I think it is. But what happens when a hospital can't discharge a patient, or what happens when a patient can't leave the hospital? I mean, there's a few different reasons. I'm sure you can tell us some of those.
Yeah.
But I've never even thought about that. I'm like, oh well, they can't leave because they're still sick. Well, but that's not always exactly it, right? So talk a little
Yeah.
bit about that situation, because that sounds like a nightmare, man.
Yeah, and it also does things to the patient, because it makes the patient feel like no, like nobody wants me, and nobody,
Right.
there's nobody there, there's no support for me, and that's a very a difficult thing to kind of like deal with and process, and of course it's going to affect your journey, your care journey after that. Um, the so hospitals are an acute institution. There's some hospitals that are a swing bed and they can take you for long-term care, or they have a nursing home that's out there in the parking lot and they can take you long-term care. But the vast majority of hospitals are acute care institutions, meaning that you do not want to be there for more than 20 days. Nothing good is going to happen at that point, right? They need to get you out. You have every single infection known to man has ever existed. Every mistake in the world can happen. There's so much that's involved in it. It's not where you want to be. And a lot of people have this idea that you're in a hospital, it's the safest place in the world. Far from it.
Well, yeah, I
It
agree with
is
that.
far, it's absolutely far from it. I mean, there's every sharp object and drug known to man, in these institutions, and it's just not a safe place. There's too much risk of something bad happening, and the statistics show after 20 days, something bad's going to happen. So
Wow.
um, and so length of stay is something that hospitals pay attention to, and there's a correlation between lengths of stay and especially in the West, where we correlate length of stay with quality of care. Um, and it's because it's the idea that things should be moving along smoothly and we should be able to go X, Y, and Z, and almost, I don't want to use the term of like an assembly line, but it really kind of sings to your flow and your processing and the
Yeah.
communication in the hospital, that your length of stay should be low. And so back, about 10 years ago, the average length of stay for a hospital was like 4.25 days, and now it's over 5. Right? It's been steadily creeping up. Patients are becoming much more complex in their clinical presentation to hospitals. There's also a lot of social determinants of health issues regarding patients. I think that would probably be, if you were to speak with a case manager, I think that would probably be the number one issue for that hospitals in their communities face, is the social determinants of health. And you may say like, well, I have I have insurance and stuff like that through my company, and and it pays for everything. It pays for everything after you meet the deductible,
Right.
and that deductible has probably been going up higher and higher for you. It's the idea that that they sell you a bigger, larger bag, and there's still just as much air or more air in it than there was potato chips.
Right.
it's
Right. It's
it
the same size bag,
yeah,
right? Same size bag that you always had, but it seems to weigh different.
right, right. And so, and really on the direct primary care side, is what makes it much more appealing, is that as a clinician, these clinicians are able to stay with their patients a lot more. They're not so much looking into their and into their checklist of what they got to treat or do next and what they have to code for next. And so that we got a lot to that. So a lot of these social determinants of health issues are very challenging. And then when a patient shows up, they're also, they're sicker, and they're older. Um, you know, before COVID, the plague in most hospitals was a 55-year-old white male on an anticoagulant, anti-diabetic, an opioid, who's been divorced for 10 years. He's been couch surfing most of that time, staying at friend's house, whoever will put up with him for a while because the ex-wife is done with it. And they're not staying on with their insurance or their Medicaid or whichever, because they don't have that, that steadiness of somebody organizing that in their life. And that guy would go to the ER, complain of chest pains. He had to be admitted a lot of times, and then the hospital's like, "Oh, what do we do with them?" Because the case, I mean, the ex-wife is tired of. She's actually blocked our phone number, to the point, and and all the friends are like, "Yeah, he can't stay with us anymore." And that's very challenging. So you come into situations where a hospital is like, what level do you feel comfortable with yourself, like type deal. And that's a very difficult question. So
Yeah.
when we first got started, that was actually one of the first types of cases we were like kind of faced with, we had to address to say, what works for that individual, and and it really is kind of like getting somebody in place in that person's life that's going to help with getting that organization back together again. And that's been very successful for that particular case. Is that guy's still around? It's like he's still there, but he needs somebody to kind of like assist him in getting the services that he needs in life. Yeah, and so yeah, clinical complexity, social determinants of health, those are definitely the ones that are leading to length of stay. Payer is also another issue. The insurance back and forth going saying, yeah, we're not going to pay for post-acute care at that level that the hospital is recommending, and insurance gets may or may not be rightly so, but they get beat up a lot for that. And the thing is, though, the number of appeals that there are that a medical director is receiving, and it's not something that's in their wheelhouse, right? So let's say you have a guy who is 23 years of age. He's driving home from work one day. He has a lawn business, and he's self-insured, and he gets plowed into by a drunk driver, ends up with a TBI and traumatic brain injury. Sorry, and he's not doing too well, but the hospital does a really good job. And 2 weeks later, he's able to follow commands and that sort of stuff. And he's improving, but he's starting to stabilize. So he's not an acute patient anymore. He's really a long-term rehab patient. So he really shouldn't be in a hospital anymore. He needs to be a long-term rehab facility. The insurance company, they're going to see car accident, TBI, non-responsive, and they're going to say, yeah, that's 90% of the time that's a denial, because you have to be able to communicate in order to do therapy and understand what's going on. Otherwise, we're just throwing bad money after good. But the reality of it is the patient's the patient's improving. They get so many that they can't keep up with the amount of information. Right. And so you get this medical director, a couple appeals later, you get to the medical director, and they're like a primary care physician that's trying to pick up a few hours, maybe, if it's like, if they're doing this through Medicaid, or, if they're part of a commercial plan or something like that, then they're usually, this is their job. But they're still getting a couple hundred of these. There's no way in hell that they're getting up on all the details. Right. And so, you have a face-to-face with a neurologist or whatever, and the neurologist saying, yeah, what the patient's doing much better. And still they're like, yeah, but it says back here but that was like 2 or 3 weeks ago. So we see cases like that a lot. We'll work with groups on third party, and, go through the third party review process. And then, what steps do you have after that? We've seen that a few times, and it kind of just like played out like, this is what's going to happen. And it's not, the insurance company, the medical director of insurance company, they're not bad people. It's just, there's just so much for them to go over. It's not possible. So, I got kind of ramble a lot, but yeah, those are the issues that we really kind of see like a lot of, and it can be kind of like terrifying.
So you mentioned that there's been an increase in the time people stay in a hospital now, the average time. How much do you think that actually is? I know this sounds crazy, kind of a positive, but it's a positive in the fact that so many more things are being done outpatient now, that people are actually not being admitted for things that they were previously, right? So it's actually more serious conditions that put you in the hospital now, because so many things, even like knee replacements, hip replacements, and various different things. It's kind of crazy the things that they can do now
On the outpatient side, yeah.
That used to require a hospital stay of a day or two. So that doesn't count anymore, right? That doesn't help bring the number down, because there was never a hospital stay to begin with. Do you think that has any impact here?
That's a really good point, and I would say that that's probably part of it, because that's, central services in the hospital will tell you that, that surgery is probably, especially those elective ones, is probably pretty important. When we were, in the recession a few years back, one of the areas that we were looking at with hospital systems to see like, what the trends, what they were seeing the trends were being, was we were looking at essential services, and essential services was hiring for their hospital system. So essential services, they're the ones that do like all the garments, the utensils, devices, all that sort of stuff. They're the ones that kind of like process that, get that ready to go. And so if you're hiring people on there, then you're planning on booking and scheduling more of these surgeries, and we weren't seeing an uptick in those. And so we're like, shit, this is going to be a while. This is going to be a long time. It's kind of like in construction. When you go through a construction-based recession, you kind of wait for the cranes to come down, right? When the cranes come down, then you kind of like go, okay, now we probably reached rock bottom. And that's sort of like the same thing. And so I would going back to your question there, I would probably say it has something to do with it. The amount that we're talking about here, the gain of over a day in length of stay is tremendous, and they didn't quite have that to begin with. So one of the benefits of doing this, outpatient only, is because we are getting more and more of our population is of the age where they're going to require knee and hip surgeries, and so it's just on bed volume. You're going to want to be able to do that outside, and so a hospital will split the billing with a surgical group, for example. But if a census generated, that's going to be a challenge.
So now on the other side of that, so we talked about something that could have an impact on maybe skewing the number because more serious things are there. How much do you think, and you kind of mentioned this already, infections and other just bad things that happened have had a part of that increase? So, you said that increase of a day, that's pretty major. Well, how much have potentially bad things that happen at the hospital? We all hear the story. Yeah. Well, he was sick when he got there, but he was a whole lot sicker after he got there because of these other things. How much of an impact does that have?
So we see when we get a case packet for a patient, or a family reaches out to us regarding a loved one, and the patient's been there for at least 20 days, there's a pretty much 100% guarantee that there has been an accident at some point along the way that has resulted in that patient being there longer than what they need to be. Now, if it's a hospital-acquired infection, that can range from anywhere from 3 or 4 days. It depends on how they respond to meropenem or whatever medications that they're using, to weeks. If there's a cardiovascular event that takes place at the hospital, that we could be looking at something much longer. And we have a case with an academic trauma center, and this wasn't any fault of the hospital. The guy wasn't able to make decisions anymore, and his guardian resigned. It's actually durable power of attorney resigned. So I would always say to make sure that your durable power of attorney is somebody who has agreed to hold that position for you.
Oh,
you can assign anybody you want to. If you want to assign a president of the United States, you can say the president of the United States is going to be my durable power of attorney. Whether or not they're actually going to do it, it's a different story, right? I mean that's the thing. And so this individual, they thought they were going to put the right a certain person in there, and that person didn't want to do it, and they were concerned about being held liable for things, and usually there's protections in for durable power of attorney or individuals who hold those that are representing the rights of the patient, that they're not legally bound unless it's shown that they're acting in a way that would be mischievous, I'm going to say. And so I would say after 20 days you're nearly 100%. After 30 days you are at 100%. It's just too much. There's multiple shift changes. You have different staff. You have 3 on, 4 off. You have you're switching between hospitalists and then weekend hospitalists, and then you have case managers that are Monday through Friday, and then you have weekend case managers. we're just trying to keep up with what's going on with the ER over the weekend. I mean, there's just too much, so something's going to happen. We saw one time, it was just, and then there was like a mechanical issue. We got called in for a hospital one time where the bed literally flung and flipped the patient into the wall. Like, I'm trying to think, like, I'm like thinking like a trap or a release or something like that. And they're like basically.
I've
And
seen that on a cartoon before, but I don't
yeah,
know
I
that
know.
it's
Yeah.
ever
Like,
done happen in real
like,
life, right?
yeah, Acme Bed Company. Who are they? Who is this? Yeah. I mean, now we have a patient with a rather severe neck and back injury now. And it's
Yeah.
just, what the?
Oh my gosh.
So I mean, I don't anticipate ever seeing that ever again. But I mean, that was crazy. But yeah, that stuff happens. That is,
Wow. Wow.
and most of the time we're, so we have these issues, clinical complexity. We also have, social determinants of health. We have, of course, payer issues. But then on the post-acute care side, you got to make sure that you're going to get paid for the services, right? You got to make sure that you're not putting your current residents in danger or the families that visit the current residents in danger. Those things have to be clear. And also you have to make sure that you can, handle that patient, that you are clinically equipped to handle that patient. And that can be challenging, especially if you have a high turnover rate in staffing. And that's a challenge that a lot of post-acute care providers face as well. So we'll work with the post-acute care providers to make sure that they are going to get paid for their services. Usually it's like a letter of agreement for some of these more complex patients with the insurance company, because they say, yeah, we gave you prior authorization, but turns out the patient wasn't that sick, so we're not going to pay for all that sort of stuff. It's like, yeah, we just dumped $60,000 into the care for this patient that you're now saying that, well, the patient wasn't that bad. Yeah, that's not going to fly.
Right. And in this case, we talked about this a little before. You're saying the patient wasn't that bad, and the reality is, well, the patient's not that bad now because we did a good job, right? We helped him not be that bad. You should have saw the guy when he got here, right?
Yeah, you should have saw. Yeah. Oh yeah. Yeah. Yeah, that's a fun one. And one thing that people don't quite realize that hospitals will do is they'll probably shouldn't say this too loud. But yeah, hospitals will contract with facilities and say, hey, tell us what a daily rate, what it's going to cost to take care of this patient, and we're going to do it, because there's a hospital metric, right? And so if it's a trauma center, that hospital has to make a certain amount of money on that bed. Right. If it's a general acute care hospital, that number is obviously going to be a little bit lower, but there is a certain number that they got to make. So if that patient's just sitting in there, it's $500 to $600 just for them to turn on the lights. I mean, there's landscaping, there's electricity, there's staff, there's all those things that they have to put into those numbers. And so at some point it becomes, you don't want the patient in there anymore. You want to make sure the patient's getting the care that they deserve. You can't give that care there. Contract with a post-acute care provider and say, okay, we're going to pay you X numbers of dollars for room and board. We're going to pay for therapy, and we're going to pay for the medications. You're going to send us the therapy notes, make sure that you're doing it, and your contract's going to be good for 10 days, 20 days, or 90 days, whatever it may be. And and they'll do that. It's just.
So we've talked quite a bit about some of the hospital situations there, but let's kind of focus back on individuals and families in particular. Yeah. And when someone, I personally believe that when you got someone that's going into the hospital, the last thing on your mind right then is what's going to happen afterwards. Right? Yep. You're so focused on getting them in there and getting them fixed, getting them right, getting them well, whatever that is. Then in most cases, I won't say all the time. There's obviously some injuries and stuff that happen where life's not going to be the same. Mm-hmm. But in most cases, your hope is that it will be. At some level, it'll be the same as it was before, right? They're going to get well, regardless of what it was. They're going to get well enough that things are going to be the same. Mm-hmm. But the chances are it's not. the chances are there's going to be some level of post-acute care needed that are not just go home and go to work on Monday.
Yeah. Yeah.
So what are some good tips for family members and for individuals to think about that process? Things that you need to know before you go to the hospital to know what's going to happen and how to start planning for after you leave the hospital.
Well, the first one is advanced directives. It doesn't matter how old you are. All right. This is what I want done. Okay. Right. We have it written down. The thing is, on advanced directives, you can write in pencil. You can change your mind. You can say, the facts change and this is what I want now, like type deal. So, I have a friend of mine who, grew up with animals, and he hunted and that sort of stuff, and I've entrusted him with my advanced directives. Right, because I want somebody to sit there and and say, yeah, okay, that's good, like type deal. Like, I love my wife to death, but I don't know if she could sit there and say it, type. So we want to start off with that, but then we also want to work towards getting you back better. So we know what we want at the end, if things go bad, so that we don't have to worry about that now. Now, how is something going to get paid for, and who's going to do the care? So depending on what type of insurance that you have, we'll just go through, because it's popular right now. We'll just go through with a managed Medicare plan. Your physician may be part of a managed Medicare group. They may be a physician member or part owner for that area. And so let's say you have type 2 diabetes and you have some heart issues. So the federal government says, to manage this patient, we're going to give the insurer and the physician group here a lump sum of money to take care of this patient, right? That's what you're going to get for the next few years. And the physician will sit there and say, okay, now the physicians group is the one that's in charge of managing your care, and making sure you stay out of the hospital, because the hospital is going to be pretty expensive. The hospital is going to burn through that amount of money real quick. So they're going to ask you to jump through some hoops and check the boxes and that sort of stuff. If you get into a situation where you end up going to the hospital, you get discharged, and they're starting to look for a post-acute care placement for you. I should say, for discharge. There's facilities that are going to be in your network. So you need to contact those facilities ahead of time, those post-acute care providers ahead of time, and say, are you actually truly in network? And do you currently accept patients with that insurance? Because the rate that the insurance company may be typically paying for that facility may not be matching what is required for that patient's level of care, or care in general. So most skilled nursing facilities will run a Medicare census, and they'll also run a managed Medicare census, depending on the type of managed Medicare it is. And then they have a long-term care or Medicaid census also. So they'll break it down, and some commercial. And so they'll break it down based upon that, because at typically Medicare pays $600 a day, roughly, plus or minus in some areas, on average, for care for patients in a skilled nursing facility, much like the prison rate we were talking about before. But managed Medicare is going to pay less than that. And with Medicare, you have between 20 and 100 days. 80 of those days are going to be with a copay, of course. Managed Medicare, there's no copay, which is great. And you have this management that's helping take care of you, but you're probably most likely not going to be there for a full 100 days. You're most likely going to be there between like 8 and 14. And that's because the physician or the managed Medicare group is saying, hey, you're doing very well. Let's go ahead and send you home with home health, or let's you're not doing quite well enough. Well, so home health may be the answer for you to help you improve more. Right. So that's usually what you see. Now, that also helps the providers, save money for later for your care, or because your chances are, if you've been to the hospital once, you're probably going to be going to the hospital again, most likely within the next 6 months. So they need that little cushion. So you have you only have so much money in that pot. The other, so you want to be aware of whether or not that those post-acute care providers accept that insurance, which can be kind of a difficult subject for people to talk about, but I think we're getting a little more open about that. They may say we have a ton of providers in network, but you need to actually make sure that those facilities are accepting patients under that care. That's usually pretty key. And there could be a number of issues on there. We've done a whole host of times where we just say, hey, managed Medicare company, we have an accepting facility, but they have some concerns, and it's on the payer side. And then the insurance company's like, oh shit, our bad. We'll make sure that they get paid, or we'll even go ahead and say this is your amount right now, like type deal. They're pretty good about that. It's just very difficult for everyone to kind of like keep up on what's needed. And if you're a skilled nursing provider, you should be paying attention to this, but you're probably not. It's probably not the top thing on your list of what you're paying attention to right now. And so, it's not because anybody's trying to do a bad job or be mean. It's just that they're just not getting to it and say, hey, the rate that you guys are paying for this service, it just doesn't match the reality of what it costs us. So sorry, that's so you want to check on that to make sure that those providers that you're going to want to use are actually accepting, not just in network, but also accepting individuals with that plan. And just call and say, hey, my wife's in the hospital. We're looking at post-acute care options. She doesn't have to be in the hospital. They don't need to know. It's like, and that's a good way.
Yeah. I cannot stress how important what you just said is. And I have been through this multiple times with clients where they said, well, I got online and I looked and it shows that place is in network.
Hell, I see that all the time.
That's a great place to start.
Great place to start. Yeah, it is.
Now you can develop the list of people to call. Yep. Okay, because there's a couple of things that are going to happen there. Number one is what you just said. Are they still in network? Yep. Okay, are they still in network? And because they make it so difficult, were they ever in network? Are you even looking for the right plan? Or did you have a United HealthCare plan and you just looked for United HealthCare, but it wasn't what your plan was, right? Because you didn't know how to look for the right thing. Maybe they were covered on commercial plans, but not on Medicare Advantage, or vice versa. Or you have an individual plan, not either one of those other things, and you're looking in this other network. Or maybe you're on an HMO, not a PPO, and you're looking on the PPO network.
Yeah.
Whatever. Or you got in the EPO network. Wait, an EPO? What the heck is that? Exactly. So, or maybe you're in the POS, which some people think all of them are POS. So let's just leave that right there.
I feel like that one sometimes. I've been told I'm in that one.
But my point there is that there's a few takeaways that you've got to be sure. Number one, they're in the network. That's only going to be decided if you make that phone call, not if you just look it up. You got to make that phone call. Number two, are they accepting patients? Do they have any beds? Because maybe they are accepting new patients, but not today or not tomorrow because all their beds are full. Yeah. That can be a big deal too. And also something you said, what are you coming in for? Maybe they have new beds, but not for what the concern is, not for what is needed by your loved one. Yeah. They may not have beds available for that. That can be a big deal too. But you also gave me some very, very good advice whenever we were talking beforehand on situations where maybe you're having a very difficult time. Maybe you've got all the approvals, you have everything that you need, you actually found a location, but you just can't get in it for some reason. There's something going on. And you told me a very valuable piece of information, and that is it's time to get the doctor involved. So talk a little bit more about that as well, Timothy, because I thought that was really important, and it's a step that we missed. It's a step that we missed. In the last few months, whenever I had a family member that was looking for that post-acute care, and we just couldn't get anyone to take him, but we missed this vital step.
Yeah. So I'm going to sound like I'm going to be speaking negatively of some people, or a lot of people, and I do apologize. I just try to state like how facts are. So especially if you're seeking post-acute care, the post-acute care, admissions person for a skilled nursing facility, or sometimes, not so much for home health because they're usually commission based, but for a skilled nursing facility, they're going to receive anywhere from 150 to 200 case packets a day. And these case packets are about 100 pages to 200 pages long. So they are going to be basically looking at, is a payer in place? Is a person a registered sex offender? What happened that brought that patient into the hospital? And are they on any expensive medications? And they're just skimming through the MAR, looking for anything that looks somewhat expensive that's on their cheat sheet over here on the right that says do not accept if they're on these things, or if they're on Haldol or something like that that indicates that there's behaviors. And they're also looking for like keywords like vent and dialysis and code gray or whatever it may be, and they'll look for those types of items in there too. And so when I see like there's something major, like a major trauma, you have 200 cases in front of you. Are you going to take the major trauma patient? Or are you going to take the 87-year-old grandmother who fell and hurt her knee? Like, you're going to take the trauma patient. I mean, I'm sorry, you're going to take the 87-year-old grandma that hurt her knee, and you're going to pass on that trauma patient because there's probably a lot going on. There's probably respiratory that's involved. We're not quite ready for using vents. We could probably do a trach or something like that, but we can't do a vent right now. We don't have the airflow or whatever it may be, or the training. And so it doesn't even get up the food chain. Then case management will reach out to the facility and say, hey, wait, you took a patient similar to this a few months back. Let me talk to the DON. And so the case manager, or the social worker or RN, they'll talk to the DON, director of nursing. Usually, I mean, she's a nurse or he's a nurse. And they'll go back and forth and they'll discuss. And that becomes a little bit sort of like a whose license is better type of standoff sometimes. It's a turf battle because you're like, this is another nurse or a social worker telling me how to do my job. That doesn't always go too well. And so what sometimes you end up resulting to is, a conversation with a physician that's in charge or a hospitalist that's overseeing that patient, when in actuality it's the case manager who's actually running the show. So the case manager is like if you think of like the patient care as a movie. Obviously, the patient is the star of the movie. The case manager is definitely the producer. The hospitalist is probably the director or something like that. Right? And so, really, they should be listening to the case manager, but they'll talk to the physician. But that physician can sit there and say how that patient is clinically presenting to that nurse. And then generally, we haven't had a situation in which the nurse has said no. On that, it's going to happen once they agree to that conversation, and really they're looking for clinician to clinician because they still see that doctor as being a clinician. They don't see the case manager as being a clinician anymore. They see that person as being an administrator, but as a clinician telling them this is while the patient's presenting and this is what you can do for that patient, and that's like and that's pulled through. But the thing is, that's actually kind of good on that. They're on the same page. And they understand what the expectation is, what does a good job look like in this case, right? And now they're going to get it. We generally have some pretty good results on that as far as care goes. It shouldn't have to get to that situation, but when it does, that's typically what we want to do. So you want the hospitalist who's very familiar with that patient, who's been working on the patient most recently or longest time. You don't want the weekend hospitalist doing that, right?
No, and I think that's just so important that there are times when, as the old saying goes, you got to bring out the big guns, right?
Yeah.
And that's what you got to do in some cases. That you cannot be afraid to do it. You cannot be afraid, once again, to make those calls to make sure you're going to get that individual the best care. And if you reach some stone walls, then it's time to take other actions. But then there's the other side of it, right? People can actually engage with a company such as yourself, and you guys just kind of help through that process, right?
Yeah, yeah. I just tell people I kind of wish that our company didn't exist. 'Cause it's not a good sign.
Yeah,
Like,
yeah, yeah. Right, right. You
you
wish you
know,
didn't have to exist.
really
Actually,
isn't.
say it right. You wish you didn't have to do what you do because you wish it was just an easier system for people to get the care that they need.
Yeah, and there are things I'd rather do. But so I tell people it's like, so I'm passionate about it. But it's like it's more like almost like you want to strangle somebody type of passion. So I will tell you, if you probably picked up on this on the call. I am not someone that you put on speakerphone. Yeah, it's that kind of passion, right? Okay. The volume is down low, and that's close to your ear. Because yeah, it's really sort of messed up. And it's with especially with families, because they get a lot of very misleading information. Medicare isn't going to pay for this, right? It'll pay for some of it, but if you need like long term, you need something that's going to be for a long period of time. Anything that involves room and board, or anything that involves you know keeping you at home and non-skilled care, that's going to be covered through Medicaid or supplemental insurances. It's not going to be covered by Medicare, and a lot of times people think that, oh well, we just go get a CNA to give us 24-hour care under Medicare. No, it's never happened, and it never will. It's like this. I mean, and so people have a um they don't understand how it's going to all get paid for. And so Medicare isn't for necessarily like lazy people. It's for like 95% of us. The vast majority of Americans can qualify for Medicaid, or are going to require it at some point in their life. It's mind-boggling, the numbers. So I that's sort of like an area that people don't quite understand on it. We had an interesting client one time. Well, a hospital called up, and they're not far from where I live, and I know them, like personally, that type deal. And they're like, we got a case, this is what's going on. And the patient had a severe lung issue, a pulmonary fibrosis. So it's basically you have fibers that are basically growing around your lungs and making this constricting you, is making it more and more difficult to breathe. Life expectancy for a patient once diagnosed with it is about 5 years. It's terminal. There's a terminal diagnosis. And they had this patient in ICU, and this individual was they worked for state government at a pretty high level. And the family was like, what do you mean there's no options for this patient? Because we did a search, we did a placement search, we knew there wasn't. Especially at that high flow oxygen rate, like 60 liters. So that's 60 liters of pressure to keep the lungs open. It's not that you're breathing that in. That's just to keep your lungs open so that your lungs don't collapse and you don't suffocate, right? It's not that you're breathing 60 liters of oxygen. So he's very sick, very, very sick. And they were like, what do you mean there's no facilities that can take him in the state of Florida? And I was like, Bill, there are a couple, but you're looking at anywhere from 6 months to a year waiting list to get in there. And I said the closest facility is actually a swing bed facility in Georgia, who we've worked with before. They do an exceptional amount of good work. They're pretty well known. And it was actually the hospital that actually recommended the patient to there. I was like, so that would be my I told him, I was like, that would probably be like my first recommendation. Then you're looking at a university system such as UT in Texas, where they have specialists for this condition, and they might be able to work with them on a long-term solution. But the long-term solution we're talking about here is probably closer to what the physicians are saying, weeks to 2 months, right? I mean, that's basically what we're looking at here. And so And then you're looking at Rochester as the other the other option, and they were pretty irate. And and I understandably so.
Sure.
But people have to kind of understand that it's like there, if the reimbursement rate isn't there to $217 to $280 is what your typical skilled nursing facility gets reimbursed for a patient on event. And that's after Medicare is done. These are Medicare is only going to pay if the person's getting actual active therapy, and then it's Medicaid's the payer. $217 or $280, whichever it may be, that is not even going to cover the medications, let alone the respiratory therapists, the pulmonologists, anybody else that's going to be coming in and seeing a loved one. And that's not just a case in the South, but we find that a lot throughout the United States. Not so much in the Northeast. Northeast is a little bit more funding on that side, but we definitely see that in the South, and that makes things very, very challenging. People have to quite understand that it's like those systems, they cost a lot of money. So that makes things challenging. So you have to balance that. So if you're going to take a event dependent patient who's not going to be coming off the event, you need to have a couple Medicares on the other side to balance it out. So, and that sounds terrible because you're
Right.
balancing out. So they're not getting the full benefit on their Medicare benefit, what they need to supplement for that other patient. And that happens a lot.
Yeah, and I've actually explained this to people the best that I can, that this is one of the reasons why you see differences in pricing, right? You see a hospital with the same exact procedure or the same exact whatever treatments cost different prices depending on the insurance. And it can be the same insurance company, right? Same exact insurance company, but if it's a Medicare patient, the pricing is typically much less than a commercial plan or an individual plan. But it's the give and take, right? We got to make it up somewhere. And so, is that fair? I'm not going to answer that question because I've got an opinion on it. I think that there's a much better way they could do it, but no one asked me, Timothy. So I'm just gonna. But that is what it is. It is truly the give and take.
So on a commercial plan, as an employer, why are you paying the insurance, right? Because you have an investment in that employee, and you need that person to return to work quickly.
Right.
So commercial insurance is basically saying, you're given a golden ticket to say, I need this person back and working, not back to their house, but back and working as soon as possible. And, so the hospital's going to say, okay, like, yeah, we can do that. We got to check to make sure that everything else is running perfectly before we're going to make sure this person's back and able to go. Medicare is definitely for a population that typically isn't working. If you're applying for Medicare, if you're a Medicare beneficiary under the age of 65, it's usually because you have you've had Social Security disability approved and you've had it for at least 2 years.
Right. Yeah.
Or it's a different
quickly because you had kidney failure, you
had
ALS
failure,
or something like that. Right. You're sick. There's a problem, right? You're sick. You're clearly got a problem.
You bring up renal failure on that, and we can talk about DaVita all day long on that one.
I bet that is a very interesting placement situation because you even brought it up when you said, here's the nursing, the skilled nursing facility looking at what's going to be needed. When they see dialysis, they're probably trying to run the other direction, right?
A lot of times,
or how it's funded. I guess depending on how it's funded, they may want that person.
They may want to do it if they have the ability to do it in-house. It's a very expensive startup cost for a lot of dialysis groups that will do dialysis at a skilled nursing facility. There's several business models that are improving that, and that they are, they're basically saying, okay, we'll do a new MPI and we'll be able to do dialysis for several of your residents in-house, but we're also going to do a contract with the hospital and be able to zip line them over, basically for patients that are no longer are approved by Fresenius or DaVita for missing appointments or whatever it may be, or clinical complexity. Because if you think of the patients requiring skilled nursing, they're probably a little bit more challenging now.
Sure.
And so DaVita, they, I don't, I'm not beating them up or anything, but they're a lot of their brick and mortars were focused on commercial insurance. They get these people dialysis, commercial insurance, and you're going to go back. You're going to go back to work next day, or very soon. And so we're looking at 3 days of treatment or whichever it may be, and that's going to be covered by the commercial insurance. But if it's end-stage renal disease, basically the courts ruled that that's a Medicare benefit, and that could be covered by Medicare, which is a slightly different reimbursement rate.
Sure.
Right. and that makes things like, okay, so where commercial insurance was helping us on the front end to kind of handle some of these more complex patients, these patients that required, a Hoyer lift or whatever it may be, they're coming from a nursing home. Now we can't assist with those patients anymore. And if the nursing home wants to work with us, the nursing home is going to have to send their own people. The nursing home will starve for staff also. So that makes things very, very challenging on that side. And so you see provider groups now popping up that will do mobile dialysis in a van, and they'll just pull up. You've seen that. To other groups that are basically taking a couple beds or a couple rooms from a skilled nursing provider and say, okay, we're going to make these your dialysis center, and we're going to lease this out from you, and we're going to set up a new NPI and split the billing with you, and that's going to set back. That's generally, you could say about $100,000 for your setup. Half of that is equipment, but that's that's a direction I think has been pretty popular for post-acute care operators. They're looking at that model a little bit more and more.
Yeah. So let's switch gears a little bit and talk about a kind of an interesting thing that you had brought up, and that is y'all have had a number of situations where patients that were going to be released from the hospital needed to find a place, but they were over 600 pounds.
Yes.
And so that brings a whole different dynamic to this, and obviously a whole lot of different complexities. So talk a little bit about, kind of that, you had one, and then all of a sudden it kind of morphed into a number of them. You're like, what's going on here, right?
Yeah. So, a lot of, we go back to the discussion we had on surgeries, right? So if you're not getting that, that the stomach staple or whatever, surgery it is, because they're not scheduling surgeries due to COVID, we had a lot of patients who, they're not getting that really needed it, and then they weren't getting that surgery done. And so we went from, in 2019, we had one case that we worked on that was a patient that was over 600 pounds. And we got in place, and then by 2022, we had, for the same area coverage, we had 24. 24 was the number. Yeah, so it was like almost every other week we were getting another case of a patient over 600 pounds that was requiring, and again, it's because their surgery had been canceled, whatever it may be, to the point that we were talking with operators about, you're going to want to put in a wing for this, and you're going to split the cost with the hospital, or you're going to split the cost with an insurance company, because insurance companies were paying. In one case, we had an insurance company paying $1,100 a day for a patient because those Hoyer lifts, and what the operator was doing, what we recommended they do, was to basically, as they were generating a new bariatric unit, bring your PT to the rooms. Don't have the patient transition to PT. Bring the PT to the rooms. All the equipment is in those rooms. If you had, because the building in particular, they had originally they had quads, right? So this is a building that was like built back in the 70s. They had quads, 4-door room. You can't really do that anymore, right? So, and plus patients are bariatric, so you're going to throw out 2 of those beds, probably even 3 of those beds, and you're going to put in equipment in there so that you don't have to transfer the patient nearly as much. If you get to the patient's edge of bed, you're ready to go. And so they set up their rooms like that, and yeah, it was over in South Carolina, and in a hot minute they had that building full. I think the insurance company was actually working with them directly. didn't even use us anymore after that. It was like, new phone, who's this? Like this hang up.
Yeah, after a little, after
Whatever.
the 10th or 15th one or whatever, they're like, okay, we don't even need to talk to
Yeah,
those
we
guys
know where the
anymore. We know
patient's
how to
going.
do this.
Thanks. But yeah, like $1,100 a day. And so if you go back to what we were talking about before, Medicare high-end reimbursement for Medicare was like $600 a day. And so if you're able to get $1,100 a day, on that bed, that's not a bad day, right? And so the transportation costs, the transportation was an interesting issue on that because on some of those cases, because most of your ambulance beds are certified rated to 750 pounds. And I guess for insurance reasons, they don't really want to get close to that.
Sure.
700 is about what they will what they will feel comfortable with. And so that's a challenge. That was a challenge too, to find an ambulance provider for some of these cases in which they could take somebody that was over that.
Oh yeah, I can see that. But once again, there's a liability there, right?
Yeah.
Even if your bed says that it can do that, that's like I'm going to go zip lining and the maximum weight is 250 pounds, but I weigh 245. I mean, think about it. Do I
Yeah,
really want to go zip lining?
let's just pause on that one, okay?
I
So
think
yeah,
I'm going to pass this time.
yeah, well, the one case that we had that was before 2019 of the 600-pound individual, the patient actually originally started off about 350 pounds. They were a 4-person transfer for a medical appointment. They were being moved from their apartment, and the ambulance team didn't wait for the other crew, and they took the patient and they dropped her. And so she went from 350 to 600 just based upon steroids and painkillers because she crushed vertebrae, right? I mean, it was just like that was a bad day. And so then we're getting called. Can we assist with that patient? So yeah, it's no joke, serious issue. Her fiance stuck with her like the entire time. Bless his heart. He was a good guy.
Wow. So obviously that's just a bad situation that got worse
Got much
because
worse. Yeah.
because the correct care wasn't given
Yeah.
at this one time, and obviously then it just exploded into a whole nother issue.
Yeah.
Wow.
Yeah, and it led to other issues because that was the only medical transport provider that was contracted in that area. And of course we're having to transport her now to someplace else, and they can't do it. So we had to work around that. So the hospital was good about that though.
Well, that's
There's
good.
like all we need to know is what size gurney do we need, and we'll just load them up.
Yeah. Well, what other challenges that we haven't addressed can folks anticipate? I mean, you don't, and when I say it, kind of the worst case scenario test, I think a lot of the things that you can anticipate, we've talked a lot about those. But what are some of the other kind of outliers that you've seen or other situations that, if this, then you need to look for that. And if this, maybe you need to look at that. And, maybe those are the things that you just really have to address as they come up. And I'm sure that y'all have done other ones, but they maybe be so infrequent that it's just not something to even, put out there.
Yeah. I would be, like I said, be aware of the providers first and foremost, but there's no possible way that you can be ready for any circumstance or all the circumstances. Think about like after 9/11, right? Everybody was spitballing ideas about what the next terrorist attack was going to be. And you quickly find out it's pretty much impossible to correctly identify what the next attack was going to be, if there was going to be one, right? There's too many, there's too many things. So what you really need to put in place is, okay, what's our general culture or concept of what we're going to try to accomplish, and what's our limits for each level, right? So if by setting limits, you can correctly, you can get the proper expectations of what level of care or what level of recovery you can anticipate, right? So and that's really kind of starts again off with the sort of like the advanced directives, but also being aware of what the providers in your area can are actually a network, and also knowing what they can do. Not many of your providers can do vent dialysis even for a short time. If you're a family, if you're thinking about your children, the number of pediatric facilities is very low. But to the point that we really don't even work too much on pediatrics, because they're pretty much known across the nation, like who they are. I mean, and that's, I mean, which is good and bad, right? I mean, it definitely shows that there's probably need in that area, but we all have a pretty good idea for what it is. And so, but like I have like at least have like a decent idea of like what conceptually what you can do, or what your limits are, because it's very difficult again to sort of like anticipate everything that could possibly happen.
No, well, that's exactly right. And I think you gave us some great tips on some general overall things you can do with the first one, making sure that what you want, your wishes are out there, that they're well known and they are documented. Because exactly what you said. I mean, I've seen it, I've heard it from family members, from friends, from clients, and things that didn't go the way that you may have felt that person really wanted, but because there was nothing in writing and there was nothing there, then there are people making decisions that are in the worst position of their lives to make this position, quite honestly.
Yeah. There's I have a couple of hospitals nearby, and years ago, actually, to the extreme measure, I told a couple of the ICU nurses, it's like, listen, it's not looking that good. Just just oops. Like, I mean, really, I mean, just let me go, like it off, that's fine, it's, but like I said, you want those to be known,
Yeah.
and then everything else, you want to know what's available, and then how is it going to get paid for.
Yeah.
So this kind of puts you into, I'll give you a couple of things here. There is an entire health industry that exists in the United States and doesn't exist anywhere else in the world. And it's called the LTAC. That's the long-term acute care hospital. I don't think it exists anywhere else in the world, but and basically these are patients who are ICU appropriate. But for a lot of these cases or patients, now there's a lot of patients that make phenomenal recovery in the LTAC, but again, hospital is acute, LTAC is long-term. So it's long-term acute care hospital. Right? Your general hospitals are just short-term acute care hospitals.
Right.
So LTACs, it's the Russian nesting doll of healthcare. They're usually in another hospital, and it's another ICU. And for a lot of the patients there, it's for families who haven't had a reasonable conversation of what quality of life is all about. All right, because if you're in an LTAC, it ain't looking good. It's tough. Now, there's a good percentage of people who make it out of LTACs, but when you compare a well-equipped skilled nursing facility and an LTAC, the numbers are identical, right?
Hmm.
So we see this in the Midwest. So northern Texas, go up straight north to the Canadian border. There's very few LTACs in that area. It's predominantly skilled nursing facilities is going to be your major post-acute care provider. and they're pulling the same numbers that LTACs do. So New York State, there's no more LTACs. New Jersey, I don't think they have any more either, right? And so, in the Northeast, there's a lot of good healthcare up there in the Northeast. There's a lot of really good healthcare up there, okay? And if LTACs aren't making it up there, that really kind of, because skilled nursing facilities can take up what they can't do. And it's so I said it's an industry that exists right now that's primarily for individuals who really haven't had a clear conversation or discussion about what someone's intentions or wishes are. They have a lot of challenges right now, and so I kind of like I never have a good. The healthcare discussions I have are never like all rosy and happy and stuff like that. It's just not.
Well, but it's the reality of it, right? And one of the things I want to point out too is we all, when we're with someone who's in the hospital, we always want to have the impression that things are going to work out good and that they're going to be just fine. But there's really nothing wrong with planning for if
Right.
things. If there are things that don't go well, what are we going to do? So even if you're in the midst of a hospital stay with a loved one, with friends, family, with whatever, maybe it's a friend that you have been kind of put in charge of helping through a situation, a church member or somebody that you're walking through this, because maybe you're the one that has the best knowledge. Maybe your knowledge was listening to this podcast and that put you ahead of the game, right? That's the case. There's nothing wrong with making a plan. Right. In fact, everything is right with making a plan. The worst part, the worst case scenario then is you didn't have to use it because everything went better than expected and they didn't need that care. But what if they do? Having that plan in place to help them in that transition to that post-acute care can do nothing but benefit them in the long run, can still help them reach that goal of getting back to a normal life. Because if they don't get that care that they need, that post-acute care, there may be no chance of them ever getting back to that situation. So don't feel bad about making plans. Don't think you're being a negative Nelly. Don't think that, it's going to be a self-fulfilling prophecy. If I start doing all this stuff, that's what's going to happen. That is simply not true. You're planning, and there is nothing but good that can happen from planning.
Yeah, it's like people like back in the day when they would, whenever they talk about a disease, like they'll say cancer, but it's like cancer, it's like they don't say it too loud, they think they're gonna get it,
Right.
And the other thing, when you go to the hospital, really that case manager, like I mentioned, or a case manager, care manager, I've said it before, I'll say it again, they're generally the smartest people in the building. They are like I know like neurosurgeons and stuff like that are really brilliant people and that sort of stuff. But if I need somebody to, if I'm in an emergency and I need somebody to pull through and do some things for me and get some things done right, it's the case manager is the person I'm going to be calling, because that person can get the tire changed, they can schedule transport. They can check everything else out in the car that's working fine. They can do all those things in one hand, while on the phone with somebody else having a conversation about, whatever it may be. And so I would, whenever you have a loved one or a friend, or you're the healthcare chauffeur for that individual, that patient, that case manager should be your best friend. And the thing is, though, they're trying to solve, 20 years of issues in 72 hours, and they're trying to do that for 26 other people at the same time. Right. So they do have their hands full, but if you're making them your best friend, that's going to help your patient out, and it's going to help them out a lot, because you usually they just get beat down by everybody. They have multiple external customers that they have to deal with, but they have double the amount of internal customers that they have to deal with. And that makes it a very challenging role.
Yeah, absolutely.
So, we work with a lot of case managers, and 99% of them are some of the very, very best people we've ever had the privilege to work with.
That is also great advice. A lot of insurance companies also have case managers, and I've recommended to people many times that can be your best friend, because in many cases, in almost every case for a case manager for an insurance company, while they are paid by the insurance company, they are actually agnostic. So they are paid to be your representative, quite honestly. So they represent the client, not the insurance company. And the insurance company is actually required by law to pay them to be agnostic in that situation and give you the best advice. So case managers, they may get a bad rap in some industries, but in healthcare, a case manager can be your biggest advocate and your biggest help in so many different ways. So don't ever, overlook using that case manager.
An interesting story for speaking on the insurance side of case management. It was a young insurance company. They were a national brand, and so we were working with this pretty complex case. The patient had actually been at another hospital before, and she was discharged to an unlicensed facility because they couldn't get her placed, and she ended up showing up at a hospital that we work with, and we ended up getting a case, and we got her placed pretty quickly. Because we got her signed up on essentially on an Obamacare plan, right? She didn't qualify for Medicaid, didn't qualify for Medicare, obviously, because she's not disabled. Well, not at the time, she would have been declared disabled. But so we had to get her onto an Obamacare plan. And as a new company and new case manager, and I kind of like talked to her. I said, well, this is the case with our patient, and this is what's been going on, and these are the accepting facilities we got. And new case manager, she's like, well, I'm probably going to get fired, but I'm going to go ahead and approve all these. and she set it up, and it was just like, and she wasn't there for very long. And we get the next case manager, which is her supervisor, and she's like, oh yeah, I'm well aware of this case. And she's like, don't worry, like we're going to pull it through on this young lady. And then about 6 months later, she's like, has this young lady qualified for Medicaid yet? We've got a lot of heat. Like, let me talk to the family.
Oh gosh, yeah.
Yeah, I mean, but so they, like I said, like, they know what's coming, but it's like, they do it, so that was pretty awesome of them.
Yeah.
I don't think it was just that. I think it was probably as a remote job. She was working at home. She's like, I could probably get paid doing remote more someplace else.
Yeah.
or the kids are driving up the wall.
Yeah, but I would think it's got to be somewhat difficult for any of those folks, because I mean, you're dealing with people in some of the worst circumstances of their life. And you're hearing some terrible stories about things that happen to people and the amount of care that they need. And so there's got to be some, just like anyone, hearing these stories all the time. I mean, if you're a case manager, no one's coming to you because I need to have an ingrown nail removed. People are coming to you because, they've got some stuff going on, right? They've got some pretty serious situations that you now have, and they're seeking help for. So it's got to be somewhat taxing hearing some of the situations as well. So I got to have some empathy for them, and the fact that they do such a good job, there's something to be said for that. It takes a special person.
Oh, it's a tough job. I really kind of hope like this next evolution of healthcare. I really kind of hopes that the case manager position kind of like takes a much more prominent role in it, because they definitely do have the right one at the center of what we are trying to do here, and it's definitely the patient. So they do a phenomenal job. It's a thankless job. I mean, it really is. I mean, I don't know if pizza parties cover it.
No, you're right.
It's like,
but here is what has kind of come out of that. And so, of course, we work with mostly on the self-funded world and putting plans together and building our own stacks and working with awesome groups with nurse navigators, and what would then be considered the part of your navigation and stuff through traditional insurance. But these folks are hired, and they're typically nurses and are clinicians that are helping guide you through this system so that you're never alone through it. And that is one of the things that make these plans work so much better, is that navigation and advocacy. And I know you guys do some of that as well in helping folks that kind of get with you before their journey through the hospital system. But that's really what sets these plans apart and gives it another layer that your traditional BUCA plans don't do for their clients. Their answer in most cases is, well, look online and find something that's in the network. And that's it. That's as much as they're going to help you in the front end, guiding you. You really have to get in a more serious situation before you will get a case manager, or you'll get your own advocate. But in a well-designed health plan that is making sure you get to the right care at the right place at the right time, that is not going to be the case. You're going to have someone walk with you for that ingrown toenail. If you want them to, they're there for you. They're going to help make sure you get to the right doctor for that ingrown toenail, and you get the best care for that, because there's nothing too little or too big that they won't help you get through. So that is one of the dramatic differences that you can see through a well-orchestrated health plan that you as the employer will have more control over. So if you guys are ever interested in that, then please reach out to us at Eagle Care Health Solutions, because we want to help guide you down that direction. And, even if you don't work with us, at least you'll understand how those plans work better, and we can guide you to a network of other folks like us that build plans. Even if you want someone closer in your area, we'll be happy to get you with them as well.
Excellent.
All right. Well, Timothy, I sure appreciate you spending some time with us, buddy. I mean, this has been very enlightening, great information. Folks, if you want to learn more about what they do over at ATP HealthCare, you can go to, shockingly enough, atphealthcare.com. Wow, what a novel concept. Someone whose company is also the name of their website. But to make sure you heard me clear, that's A as in Apple, T as in Timothy, P as in Paul, healthcare.com. You go out there and check them out. You can see the services they have, both for providers, hospitals, also individuals. You guys do a lot of other stuff for folks. I saw you do moving and estate sales. You help folks sell their home. You can also do an insurance audit. I love the insurance audit. I do a lot of that myself. Look at people's plans and make sure that they're making the right decision, especially during open enrollment. Even for stuff I don't provide, I'll look at people's plans and say, hey, here's what your company's offering, or here's what you're different. This is the one I would recommend if it was my family. Also, of course, give more information on power of attorney, guardianship, Medicaid, help folks with that, caregivers, all the different services you got to provide. Very, very impressive. I'm sure folks can also reach you. I know I did, out on LinkedIn. And then you're also doing some tweeting. I saw you're on Twitter. I'm not much of a tweeter, or I guess we're Xers or whatever now. I don't know. I don't do much of that. But you can reach you on probably all the regular platforms as well.
Yep. And if you want to talk about artificial intelligence in healthcare, the platform is pretty robust, and it's really built around the case manager, and helping that patient and that case manager relationship throughout the care journey, not just in the hospital but into the post-acute care. And and that's a definite fun conversation. It's wild.
I'll tell you, it's something else right now. If you're listening right now and you haven't delved more into AI, you're falling behind. I mean, it's not just coming; it's here. So it wasn't long ago I was telling people it's coming. Well, it's not coming anymore. It's already here. And if you're not utilizing it, and if you're a health system in a hospital and a provider that's not using it, you're falling behind. You are falling behind quickly, and you're not going to realize how far behind you are until you realize how far behind you are. And then playing catch up is going to be really tough.
And that's probably a conversation for a different day, because the window on it is very short. We've been working with this company for several years now, and we were just kind of like just waiting and waiting to when it would be the right environment for it. And the release of ChatGPT kind of really kind of helped people understand like what this actually does, and that's it really is a very powerful tool, that it does an incredibly good job.
Yeah.
It does so many little things that just eat away on people's time and makes their days much more efficient and makes their work much more enjoyable.
Yeah, Chat GPT and some of the corresponding AI tools that are available out there, the uptake on that. So the people that started using it, it reached 100 million users. AI, what we would consider the new AI type product since Chat GPT was released, faster than anything else in the history of mankind.
Yeah.
Anything else that's ever been released. It didn't just reach it faster, it reached it faster, and it's not even close to anything else. Less than a year, and like 10 months, 100 million people were already using it. And some of the things they were comparing it to for that 100 million users were, like the iPhone, and they're just different things like that. It's not even close. It's not even close. I mean, it took years for any of the other things, multiple years for the other things to reach 100 million users, but this did it in less than a year. So if that doesn't tell you how far behind the 8 ball or how far behind you're going to be if you don't make some changes in what your adoption of AI is, then I don't know what else would, but you're falling behind, further and behind every day.
Yeah. No, you're absolutely right. And I say it's a very fun area to be looking at and exploring right now. And I will leave it at that. If anybody wants to know more, they can call us.
Yeah, absolutely. Reach out, find out how it can fit in to your system, or find out, how things are, because I'm sure, once again, that's a whole other show, but I'm sure you guys have great aspirations of other things that you're going to add into other services through that as well. So once again, we'll get together for another conversation on the AI side of that, Timothy, but I do really appreciate you being with us today and sharing your wisdom on this subject. I always think it's cool when someone never intended to be where they are, but they found their place, they found their niche, as it were, and the passion that they have for it won't let them leave. Because that's exactly what happened to me. There is zero chance when I was younger that I was going to be an insurance guy. Never would happen. Yeah. But here I am, and I can't imagine doing anything else, because until we make dramatic differences in access to healthcare in this country, I'm going to stay in insurance so I can keep finding out all the things that's wrong with it, so I can make things right for other folks too. So once again, appreciate you being here, buddy. Appreciate you being with us. And folks, y'all keep listening in. Every week, new episode of Health and Wealth Power Hour. And don't forget, the last Tuesday of every month, we do on LinkedIn Live our version of Why Does Healthcare Suck? We touch on very different subjects. We had our Halloween horror stories in October. We touched on why fee-for-service in paying doctors has been so detrimental in healthcare. In November, we talked about that with Dr. Clint Flanagan. And in December, we're actually going to do something a little bit different. We're going to give some positive. We want some happy holiday stories. So the day after Christmas, on the 26th of December, we will be sharing some happy holiday stories on beautiful outcomes and things that people have enjoyed about the healthcare system. Could be a 3 or 4 minute show. So y'all be sure and listen in. It could be the shortest show of the year, but I'll tell you what, the day after Christmas, when you're still kind of, glowing from all your presents, maybe you'll have a good story to share with us too. Thanks a lot for being with us, and we'll catch you next time on the Health and Wealth Power Hour. We are out.